Neurology is complicated. Enough said. It's hard to practice medicine, and it's hard to do surgery. It's hard to know everything about pharmacology and radiology and evidence-based clinical practice. There's just no way to know it all. So we have shortcuts. Your focused history and physical assessment. How you take one potentially loaded consultation or chief complaint.
My mother's been having trouble walking lately.
And you distill it down into something practical, approachable, and solvable.
So it seems to me she's been moving more slowly and also has a new hand tremor.
And with this framework, you're able to pivot. You go from a scattered, disorganized, endless barrage of questions.
Any changes in your sleep habits? Any other new symptoms you've noticed? Any recent changes in medication?
To a set of more focused, highly targeted questions and examination maneuvers.
Has your partner noticed you act out your dreams? Any changes in taste or smell? Have you taken anything for nausea or any medication to help you sleep at night?
And with this focused assessment, you're able to quickly reach your diagnosis, or narrow your differential, and effectively develop a management plan. Welcome back to Brainwaves, a podcast about neurology and medicine, and all the fascinating science and history that come with it. Today on our program, the art of the pivot. The importance of not just obtaining a thorough history and medical exam, but listening and responding to your patient when new information presents itself. I'm Jim Siegler. Don't go anywhere. Today's show comes in 3 parts, 3 examples of how neurologists pivot every day in the hospital and in the clinic. In part 1, we'll consider leg weakness. Part 2, a case of a patient who has headache. And part 3, a case of a patient who's coming in with falls. So, leg weakness. A few weeks ago, I was asked to see a middle-aged gentleman because he'd noticed more trouble walking over a 24-hour period. Progressive left lower extremity weakness. And think of this part of the show as a quick review of lower extremity neuroanatomy. Besides all the important questions you'll need to ask about the patient's onset of symptoms, the progression, associated signs and symptoms, exacerbating and relieving factors, all the elements of your history that you can also use to pivot with your evaluation, let's skip all that for now and take the opportunity to review an approach to isolated leg weakness. So when I meet someone with leg weakness, I start with the objective findings first. Subjective complaints like tingling, numbness, sensations of heaviness, they're more likely to fluctuate and they can be unreliable. So I'll start with the power. And we'll start proximally at the hip and we'll work our way down, beginning with the hip flexors on the affected side. For our middle-aged gentleman, his power in the hip flexors was 5 out of 5. As I'm testing this, it's kind of a mental exercise for me. What muscle groups, peripheral nerves, plexus components, roots, and central motor regions am I testing? With hip flexion, the iliopsoas muscle, femoral nerve, and L2, L3 nerve roots.
Push your knee up in the air.
Next, we move on to a different root, a different plexus component, or a different peripheral nerve. For me, the lumbosacral plexus is much more difficult to memorize than the brachial plexus, so I keep my leg evaluations simple. Roots, nerves, muscles. Knee extensors are next.
I need you to kick out your foot for me.
Rectus femoris, vastus medialis and lateralis muscles, and the femoral nerve. But L3 and L4 roots. 4- out of 5 power in this group. So we have our first finding, some weakness with knee extension. Next, we try to isolate whether it's a root, a nerve, or a muscle process. So I pivot. Which part of the leg can I test that shares either a root or a nerve with the knee extensors? The hip adductors.
I need you to bring your knees together.
L2, L3, and L4 roots, roots which also give off the femoral nerve, but the hip adductors are innervated predominantly by the obturator nerve.
Really squeeze your knees in.
5 out of 5 power in our patient. So our patient's weakness is not likely to be related to an L2, L3, or an L4 root process. The hip flexor compartment was strong, L2, L3 root, psoas muscle, and the hip adductors were strong, L3, L4 root. So we're left with the most likely distal femoral nerve disease, mild L4 root problem, an L4 radiculopathy, or a problem with the quadriceps, a myopathy. A myopathy affecting one muscle group is unusual, so really we're thinking distal femoral neuropathy or an L4 radiculopathy. Here we pivot again. What other muscles are innervated by the L4 root and not the femoral nerve? We've already checked the hip adductor compartment. Again, that's the L2, L3, and L4 roots, obturator nerve. But there can be variations in anatomy, and with such redundant innervation, it's possible that other intact roots may compensate for a single root problem. We move on to the ankle dorsiflexors, L4 and L5 root-mediated, deep perineal branch of the sciatic nerve, tibialis anterior muscle, 5 out of 5 strength. Now we're confident that it's not just an L4 radiculopathy. This leaves us with our final diagnosis, a distal femoral neuropathy. It turns out this patient underwent an endovascular repair of an abdominal aortic aneurysm, which involved the placement of a sheath through the femoral artery, which abuts the femoral nerve in the groin, just distal to the iliopsoas muscle. And either due to irritation or from accidental ligation during closure of the artery, the femoral nerve happened to be injured. We could have taken a pivot at the very beginning of the story, started with a focused assessment of the femoral nerve injury given the recent femoral arterial puncture, or we could have pivoted in a different direction, considering spinal cord infarction following a AAA repair, and proceeded with a focused assessment of the lower thoracic and lumbar spinal cord. No approach to this is wrong, but you should try to use a practical heuristic when you approach a problem. Think about what it is you're testing and what you're looking for, and react to the new information as it presents itself.
A woman was referred to my clinic for the management of migraine headaches.
This is Dr. Meenal Patel, a senior neurology resident at Cooper University Hospital, who will be discussing our second case.
She was new to me, in her 70s, and had never been seen by a neurologist before. She saw her primary care physician a few weeks earlier, and he started her on amitriptyline for the headaches, as she had success with this medication in the past. Prior to the appointment, I made the assumption that this lady had migraines, like most of my headache patients, and my routine for migraine evaluation is to review prior meds that she had taken, which ones helped, which ones didn't, and then to have her describe the features and frequency of the pain. After exchanging pleasantries, I asked her to describe the headaches. She said that they were right-sided and described the pain as an intense but brief, shock-like pain that had become more frequent in the last 6 months. She had similar symptoms in the past, but it would only occur a few times a year. She said it felt like lightning bolts. So this is not consistent with the pain of a migraine. So at that point, I had to rethink my initial plan. Migraines are often unilateral, throbbing, and last several hours, and they're associated with nausea and sensitivity to light and sound. I asked her about these other features next, which she denied. Her attacks were really nothing like a migraine. Her attacks were very short-lasting, sharp, and occurred many times throughout the day. The only similarity to migraines that her headaches shared would be the lateralizing component, but many other headaches can be lateralizing. So I pivoted, focusing on the laterality and the shortness of the pain. Could this have been one of the trigeminal autonomic cephalalgias or trigeminal neuralgia? The brief duration made me consider either SUNCT or SUNA, short-lasting, unilateral autonomic cephalalgias. So I asked about any associated autonomic symptoms: conjunctival injection, tearing, rhinorrhea, eyelid edema, forehead sweating, or ptosis. Nope. So unlikely to be a trigeminal autonomic cephalalgia. But what about a trigeminal neuralgia? Brief, sharp, lancinating hemifacial pains which happen dozens of times a day, lasting for a split second. And the description and duration of the pain that she had originally given me was consistent: brief, electric, unilateral. I asked her to be more specific with regards to the location as well as triggers. Her pain was located around the right ear, jaw, and back of the tongue, which would be unusual locations for trigeminal neuralgia, as this characteristically involves jaw, cheek, or forehead. So maybe not a neuralgia of the trigeminal nerve, but perhaps a different nerve. Similar pathologies have been known to occur with other cranial nerves, like vestibular paroxysma, which produces brief recurrent episodes of dizziness. Maybe another sensory cranial nerve could be affected. Her pain localized to the jaw and tongue, so I proceeded to ask about tongue and oropharyngeal movements and sensations which could trigger the pain. She said that swallowing and coughing typically brought on the pain. I'm not going to lie, this next part brought me back to some basic neuroanatomy. I had to recall what common cranial nerve links sensation to the ear, jaw, and tongue, or relates to the motor function of swallowing and coughing. The glossopharyngeal nerve. The ninth cranial nerve has sensory branches which carry tactile information from the inner ear and posterior third of the tongue, and it has a motor branch which elevates the palate during swallowing and coughing. Could she have a neuralgia affecting the glossopharyngeal nerve? Classically, neuralgias are highly responsive to tricyclic antidepressants, carbamazepine, and gabapentin, and she had taken amitriptyline in the past with mild improvement. So at this point, I felt pretty confident that her symptoms were most consistent with the rare headache disorder, glossopharyngeal neuralgia. She was hesitant to try different medications, and our plan was to slowly titrate her amitriptyline from 10 milligrams to 50 milligrams. And if she continued to have pain, she would then be amenable to trying carbamazepine. In the meantime, we would order an MRI and MRA of the head to evaluate for any vascular compression of the ninth cranial nerve or space-occupying lesion of the medulla, which could account for her symptoms.
And finally, case number 3, brought to us by Dr. Jesse Tone, a neurohospitalist who works with me at Cooper University Hospital.
Conditions. Our team received a call from the emergency department about a 65-year-old man who had just presented to the hospital at the urging of his wife. Per the ED's report, the patient himself didn't think that anything was wrong, but his wife was concerned that he wasn't moving his left side normally. Let's pause for a moment right away. At this point, that is all the information we had, and it's hard to draw any diagnostic conclusions from that. We don't yet know about the acuity of his symptoms, the severity, or even what parts of the body, if any, are involved. I mean, the patient himself does not think anything is the matter, so it's unclear how concerned we should be. I will say, though, that the patient's wife was concerned enough to bring the patient to the ED, and so it's important we head down immediately to evaluate him. A lot can be gleaned just by first observing a patient on initial interaction, and can allow us to make our first pivot to considering a certain set of possible diagnoses based on what we're seeing. For this patient, as we entered the room, we saw that he raised his right arm to scratch his temple, but his left arm was still at his side in the bed. Also, we approached his bed from the left side, which is where his wife was sitting, and as she greeted us, the patient didn't look over at either her or us. So this was immediately concerning to us for potential gross signs of left hemiparesis and neglect. And so at this point, we pivoted to think that a right cerebral hemispheric process may be the cause of the patient's symptoms. Now, we clearly needed a better history, and after quickly introducing ourselves, we asked the patient and his wife what symptoms led to them presenting to the hospital. An open-ended question to start often provides the most valuable information, even in situations when time may be of the essence. The patient said, "Nothing is wrong as far as I can tell. She worries too much." And he said this with mildly dysarthric speech, which we made note of. His wife then relayed that that morning at breakfast, everything was fine. He's left-handed and had no problems using his fork with his left hand to eat. But then shortly afterward, he fell in the living room and didn't seem to be moving his left side at all. So we have to again pivot at this point. Now we know this is an acute process, and in a 65-year-old man with left hemiparesis and potential neglect, we are concerned that he may have anosognosia given his lack of awareness of symptoms. An acute right MCA territory stroke quickly rises to the top of our differential, and we need to act fast. We subsequently also learned that he has atrial fibrillation and is not on anticoagulation, thus raising our suspicion even higher. We now need to pivot to potential treatment considerations. If this is a right MCA stroke, we need to determine whether he's in the time window for IV thrombolysis and whether he may have a large vessel occlusion that would be amenable to endovascular therapy. This is now an emergency situation. His wife reports that she is sure he was asymptomatic at breakfast 2 hours ago. We now need to do a rapid neurological assessment to determine whether his symptoms fit a stroke syndrome and whether he has disabling deficits, which would qualify him to receive IV thrombolysis as he's within the 4.5-hour time window. An NIH stroke scale assessment is a good standardized way to quickly get this information, and then we can do further detailed testing to clarify more subtle deficits and distal deficits, especially hand weakness, which can be disabling. While performing this assessment, another member of the team is confirming with his wife that he has no contraindications to IV thrombolysis. Things like anticoagulant use, recent major surgery, bleeding, intracranial or otherwise, or stroke are high-yield questions. We determined his NIH stroke scale score to be 15. He scored points for a mild right gaze preference, a left homonymous hemianopia, left facial weakness, which only became apparent when smiling, left arm more than left leg weakness, as well as left sensory loss. It can be difficult to determine sensory loss in a patient with neglect, but when we applied noxious stimulation to the left side, he didn't react at all. He also scored points for dysarthria and, of course, the left-sided neglect. These deficits confirmed a high likelihood of a right MCA stroke that are disabling, and given the cortical signs of gaze preference, homonymous hemianopia, and neglect, as well as the predominance of face and arm weakness, we pivot to thinking there's a high suspicion for a large vessel occlusion. We now need to rule out an ICH with a head CT and explain to the patient and his wife our concern for a stroke, as well as the risks and benefits of IV thrombolysis. In this situation, because the patient had anosognosia and thus could not reasonably assess the risks and benefits, given that he didn't even think he had deficits, His wife consented for IV thrombolysis and subsequently to endovascular therapy when a proximal right M2 occlusion was seen on CT angiogram. Due to our rapid pivoting in this case, the patient was treated with IV tenecteplase and mechanical thrombectomy, and he was ultimately discharged from the hospital without any deficits.
That's it for another week of the Brainwaves podcast. Thanks so much for tuning in. As a reminder, Brainwaves is intended for medical education only, and it should not be used for routine clinical decision making. This week's episode of Brainwaves was produced by myself, Jim Siegler, with Dr. Jesse Tone and Dr. Meenal Patel. Voiceovers by Taryn Hester and Terry Yeager. Music for our program today was courtesy of Lee Rosevear, Raphael Archangel, Ease, Jamie Jams, Kai Engel, and John Watts under a Creative Commons license. Our theme song was composed by Timothy Dalton. Sound effects by Mike Koenig and Daniel Simeone. For more information on what was discussed on the show, as always, please take a look at our show notes for the references to the highest yield literature on the topics, and follow us on Twitter at Brainwaves Audio. I'm Jim Siegler. Talk to you soon.
Is that good?
Yeah. It's a podcast, so it is cheesy.
I want to do like the whole thing again. Can I?
If you want to, you can. Like you're talking normally like, no, that's